All right, you guys. So when you're doing the IV checkoff, you'll want to have your IV start kit, extension tubing, couple needles, a flush. I usually bring extra cleaning pads, but there is a cleaning pad inside of your start kit. So as I'm setting up my field, the first thing I would indicate is why the patient is getting an IV. For most patients in the hospital, it's a safety measure. So they get an IV, so just in case they have a medical emergency, we have an access for them. So almost every single person will have an IV. But sometimes patients have a hard time with that. They'll say, but I don't have an IV ordered. Why do I have to have one? And that's your job to say, it's for safety. If a medical emergency were to happen, it's really hard for us at that point to get an IV. The easiest time for us to get early, the early medication in is if you have an IV site already that's usable. So we'll try to keep one in you while you're in hospital. And that generally makes sense. If you say something like, it's policy, that doesn't go well. It's not a good reason. Most thinking people will dismiss that and say you don't know what you're talking about. So most people need an IV. In this IV start kit, you actually have gloves in there. You do not need to be sterile. They do include sterile gloves. You only need clean gloves, excuse me. You'll have a tourniquet. A thing of tape is in there. A packet of gloves, like I said, you don't need to be sterile. This is called a Tegaderm. That's our coverage for the site. A piece of gauze. If they're on aspirin or Coumadin or something at home, I would get a stack of gauze. And I always do an IV on top of chucks. I don't know how many people I've seen go in very confidently, oh, I'm the best at IVs, and they don't bring a chucks underneath. That's the perfect time for a person to bleed all over the bed. So the best way to prevent that is just having a chucks under everyone. It's totally fine. And then this is actually what we use to clean. So if I'm setting up my area, I keep this container I just got everything out of to the side, and I usually apply my tape to that. The reason is I don't want to take tape and put it on my bedside table. Bedside tables are gross. Oh my gosh, the things that have been on bedside tables. So I'd rather you take off a couple pieces of tape and hang it off your site here. So it's just been opened by you. When you're setting up, please have clean hands, but you don't need to have gloves on yet because nothing is open. So I have a couple pieces of tape. I'm going to set out my Tegaderm somewhere I can easily reach it, next to my gauze. And I have my cleaner and my tourniquet. I'm going to set up my extension set. So here's an extension set. I don't want to be touching all over this thing because this part is going to screw into the blue part of my needle. So if I take this out and start touching it, this little cap, now I'm touching the inside of the person's vein, basically. So keep the cap on there, but definitely loosen it right now, because this is hard to take off. And if you've only got one hand, it's even harder to take off. So when you're setting it up, you open this container, loosen the cap, put it back on there. And then this other side, this blue side, you're going to attach to a flush. You must do this part in advance. It is considered part of setting up your field. The reason is if you have to do that while you've got one hand attached to a bleeding arm, you'll never be able to unscrew the cap, attach it, flush it. It becomes a mess. So as part of the setup, I'm going to take this blue thing and attach a flush. And then not right over the patient, but maybe inside this little bag, I'm going to tap a little bit of fluid through that. I am priming this tube. So just tap a little bit of fluid through. You'll see fluid just drip here. That's totally fine. Keep it to the side. This is perfect, where it's just, see? On the flush, do you kind of pull it back a little bit first? Nope. You just tap it forward.
I think everybody does it different. Oh, okay. Yeah, our clinical, our OB clinical instructor gave us a little trick, but
so that you don't push it and it goes everywhere. But I think it's because you already had yours in your extension.
Uh-huh.
Yeah.
OBs are a little different.
I think she said just to like unlock it. To break the break.
Yeah, because she doesn't want you standing here like this in front of the patient and be like, yeah, it would get the patient. But you're holding it in a piece of tubing in a bag. You're tapping it. So that's another thing. I would never just go.
So would that be maybe?
Although it's really fun at night. We actually do this at night. We should have wars.
Like unlocking it or breaking the seal if the IV's already in and we're just gonna flush?
You don't have to.
You don't have to do it either?
No. It's actually really helpful if there's a little bit of pressure there because you want to dislodge any minor clot, minor fibrin that's building up.
Okay.
But, you know, pulling it back is fine. It's not a bad technique. We're just different. We have different focuses. But for this one, just you're tapping it forward anyway. Just tap, 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 tap. You won't need to worry about that so much. Yeah, bathing a patient accidentally is kind of embarrassing when you're just trying to give a med. So I see her point. Okay, so I've got all my stuff set up. Notice I don't have my tourniquet on yet. What I generally do when I meet someone, how I've been accessed for IV help is I'm an ICU nurse by trade. There is almost no reason ever for us to put an IV in anyone. So we're probably the worst nurses ever to call in the hospital for IVs. But what I found is, when there's a hard IV stick, everyone calls the ICU nurse. It's bizarre. It's the wrong person to call. But I took it as an opportunity.
Is it because you guys get the patients and they already have the IV?
Of course.
Yeah.
They have central lines, IVs, art lines. There's never a reason for me to do an IV. Like zero. But the other floors will call. So when opportunity presents to keep a skill up, you go. That's I've worked with nurses who have worked for 17 years, like I have, that have never done an IV on a person. Because the standard line is, oh, he's such a hard stick. Could you come do it? For 17 years. Please don't be that person. After year 10, we expect you to have the skill down. But for people being asked, that's totally fine. I would rather just go do it. Don't be afraid of being new in this skill. You need practice to be good at it. And you're not gonna suck day one. It's gonna be okay. It's gonna be a little nerve-wracking because it's real skin, but this technique and everything is the same on this arm than a warmer arm. It's totally the same. It actually feels a little bit better here because you're not going through plastic. But the angle, the entry, the blood, it's pretty good. But the only way you get even better is by practicing. Take your opportunity now when you're identified as new or nursing students to get all the practice you can. Because when you say, oops, I messed up, they kind of laugh and go, oh, let me show you how it's done. It's not a big deal. If your nurse has been there 17 years and never done an IV, your coworkers will be mad at you for avoiding all IVs. So when I get in and meet someone who needs an IV, I sit down next to them, pull up a chair, put a tourniquet on, and sit there and stroke sideways on their arm, gently. I don't look. It is important not to be deceived by what you see. Veins that you see are not as good. It's better to feel. And we showed that on a student in the first class because she's got some good ones that you can see. I put on the tourniquet and I had them feel this nice string, long, straight, bouncy, beautiful vein that you could not see through the skin. That is a better vein to go for. So the way you feel is sideways. When you feel a ridge, you start touching it, see if it's bouncy. And that's really important for melanated skin. When you have darker skin, because you won't be able to necessarily see. One thing I do with melanated skin is I will have a light on the side, I'll turn off the light above, and I will also see shadow. But mostly it's side feeling, bounce. And we gotta know our anatomy. We gotta know where most people have nice straight veins. Personally, I try to avoid the hand as much as possible because it hurts more. It is more likely to be dislodged. There's more valves there. It's just an annoying place to have one. Forearm is ideal. AC is where they usually do it in the ER if they need some fluids fast. But if I have a choice, this would be where I go. You always avoid the 2 inches around the wrist. There's artery right there, of course. There's a lot, oh my gosh, so many nerve endings. It would really hurt the person. So if you're looking for the vein, there's a beautiful straight one that comes off your thumb, especially on your dominant side. You can only insert it, like put 3 fingers over your wrist. You can insert it above where your 3 fingers are. Always avoid this wrist cuff. It's a very dangerous area. Okay, so I've decided where I wanted to go with him. I set up my field, and now I'm going to apply my tourniquet. I'm going to go 2 inches, or, well, about 2 finger lengths above where I actually want to insert. So I'm going to go here. Apply the tourniquet. And there we go. Okay. We only have 2 minutes from now to get this thing in. So at this point, do I need to have gloves on? Yes, please. You'll start to have color changes in the arm, and you'll cut off circulation to the arm if it's tight enough. So it should be tight enough. Sometimes y'all are a little bit too nice with your very nice placement, but it's not actually cutting off any circulation. Okay, gloves on. Here's the cleaning solution that we have. You actually crack it, hear it, and you can see it turn a little moist. I take my area and I scrub the whole area for about 30 seconds. If you decide to keep going out, I wouldn't come back in. But if you want to just do a small circle, you can do this. But don't go going and then go back in, okay? So that's good. I'm supposed to let it dry. On these guys, they're plastic. They won't dry very fast. So pretend I didn't do that. It's dry now. What I don't want to see you do is a nervous tick that a lot of students do. I'm waiting for it to dry. See, I'm waiting. I'm waiting for it to dry. This is not waiting. This is actually putting your bacteria or air bacteria onto the site. So I know this is nerves, and you're showing me that you're waiting, but just actually go like this. Okay.
I love that you showed us how to wait.
It's something everyone does. They're like, I'm waiting. And you're like, you're not, though. It's just a nervous tick. I get it. All right, so now I'm ready to insert. I'm going to grab my needle. This is blue 22. I'm going to take off. I'm going to look at it. Remember, bevel has to be up, so it has the pusher thing on the top. Finger pusher on top. And I can see the bevel. I'm going to grab the arm like I own it. You'll see a different technique. Some people go like this. This is bad technique. If I miss, where am I going? I'm poking myself, and if I accidentally nicked them, I've now given myself bloodborne. So please at least keep this north clear. I prefer a bottom technique where you grab around the arm like you own it, and you pull down and back. The reason is you're pulling that vein and holding it in place. When you have a roller, when you hear that, oh, my veins roll, the problem is that the nurse is not pushing down and pulling back, because that holds the vein in place. Okay, so I'm going to insert right here. I am in the vein, but I'm not getting a blood flash. You can feel it. So it's because of our silly arm. But blood should be in this container right here, and I absolutely feel it. It's the same feeling as a person, actually. I advance a tiny bit more. Just a tiny. Yes. And then I don't push this down to the ground, but I'm flattening it a little bit, and then I'm doing this motion with my finger. Do you see it? If you could come up here real quick, I want you to see how my fingers are holding the finger guide, because I think this might help you. So I'm holding here. My finger is touching the skin, because I do not want my needle to move anymore. So I'm holding it down to the skin and touching the skin. This one is pushing forward. Do you see that? I don't want to go in with my needle, and I don't want to be pulling out my needle.
Oh, so that controls your needle there.
This is my needle.
Okay.
Do you see it coming in and out?
Yeah.
I would be serrating the inside of that person's vein right now. So I want to hold it steady and just push the plastic forward. And do you see how far the plastic is? All the way there. So I don't need to bury it like that is fine. If it stops and there's a little bit of resistance, it could have stopped at a valve, and that's fine. There's a way around that, but we don't want to bust through valves. So at this point, pretend there's blood there. No other blood will be pouring out. It's all contained here, so I have a moment to think. I'm like, woo, I got it in the vein. I'm going to take off the tourniquet. And then the next thing I'm going to do is engage my safety and attach this thing. So I'm going to hold it, pinch it here. I'm holding this. The most important thing in my life is that this stays in place. So I'm sorry over there if you can't see, but I'm going to pull this out, click, you hear it? That's the safety engaging. I'm going to twist. Blood may be pouring out. That's okay. That means I got a good vein. One thing you can do to prevent that is have one finger here to pinch off and be holding.
And that's what I was going to ask. So we'll make a mess. So is that okay with you if we just press a little bit?
You press your middle finger right here and these two fingers here. But the thing you're protecting is that this isn't sliding out and it's staying in place.
You don't cause discomfort like that?
No. You'll be done soon. I want you to hold from this thing, this little cuff, and you screw it on there. But do not allow this to twist. If you twist it, you're going to twist the catheter, and then you won't, when you're trying to flush, it actually won't flush. Okay, so now it's in. I'm excited. It looks straight. It looks good. I'm still going to make sure I'm kind of like in place. And I'm going to tap in half of this. This is the point when if I hit a valve earlier, remember valves close and then they open with fluid? So you just tap a little bit and you would advance the catheter just a hair. It's easy. It's called floating in the catheter. So So my goal is just to keep it in line. This flushes easily, so I know I'm in place. The most important thing that I'm doing here is protecting this site. Gloves are like the bane of your existence when you have tape, but you've got to be able to protect that. So now I've got it in line. It's not going to fly out on me. The next thing I'm going to do is work on this. So I would grab my pen. Check the pen. I put my initials, Mac. Date is what, 8/26, 25?
26.
26. Gauge 22. Okay. I want to cover part of the blue. I do not want to go up past the hub. And there's a little crease. The easiest place to put that is right here, so that when you push it down, it helps release this little part that you grab. It's actually made purposely like that. Doop-a-doop-a-doop-a-doop-a-doo. Get this side. Okay. At this point, I would honestly look up again and make sure my tourniquet was loose. I check about 3 or 4 times while I'm doing this, because that's my process, so that as I leave the room, I make sure it's not on them. There's your label that you wrote on is stuck on the top of this. See that? So you can put it on a couple places. I would recommend keeping it on this square so that you're not adding more tape to the patient's skin. You can either put it here or to the side. I don't recommend it having it here, but anywhere that's not right on your assessment side is fine. So right there's good. Some people use a little foam thing to put under here. I don't recommend having gauze underneath. Any gauze underneath a tegaderm has to be changed every 24 hours. It's just a normal rule in medicine. Not a lot of people abide by it, but I'm a quality manager by trade, so it like bothers me if we're not doing things for policy. So most of your kits in hospital have a little foam piece that will keep, as you can see, there's a sharp, kind of a sharp edge you could gouge in someone's skin. For those high-risk patients, you just put a little piece of that foam adhesive right there.
Like for older clients.
Anyone on steroids, their skin is paper thin.
How long can that stay there?
Forever. It's foam. Yeah. This, no. I think because it has so many holes in it and it can pull moisture into the site. But that little foam adhesive can stay there. For these sites, they're good for 48 hours to 96 hours, depending on what hospital you're in. So 4 days. But there's a caveat to that. Definitely, before you take out this one, get your new site in. If they're really hard to stick and it's been there 2 weeks and working, we're okay with it. Yeah, and so is the patient. So think of why, putting in a new one before you take out the old one. Last thing I want to do is kind of secure this, because it still could come out easily. And we do a loop. Some people will just tape it like this, right? Just like that. And that's fine. Just flat. I really like to do this. It's totally my preference. I don't care if you do it or not. I touch it to itself, and then I put it on the skin. And the reason I do that, if you notice, I have some flexibility with the tubing. It's really nice. So now if they get up and run out of their bed, they're going to be pulling at this. They're not pulling this out. So this curve is actually super important. And then just to make sure that in all this taping I didn't mess anything up, I tap in the last bit. If you're finding that you're having trouble, there's a little bit of resistance when you're tapping. This is like star status. You just pull back a tiny, tiny bit, and it usually goes great. Because it's usually pulled up with the tape a little bit. So it's still fine. It's one way to not get rid of a good thing. And then Mr. Bill had a whole bunch of Curos cups. I don't know what he did with them, but have you seen the green caps that go on things? Most hospitals require that you screw it on here. We don't like to have loose caps. But you can't, even though there's alcohol in there, we don't count that as cleaning. So when you access this site, you need to give an IV push med. You still have to get out one of these, take off that alcohol cap, and scrub, 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 scrub,
There's
scrub.
alcohol in the cap?
Yep. But what if it dried out? What if someone didn't use it properly? Like, there's so many reasons that we don't count on it, but it is supposed to reduce infection. It is absolutely required on all central lines, any open part, but now they're using them a lot for these two. Last thing I would do is make sure you close this thing, and there's a reason for that. If this person uses their arm to adjust in bed at all, the backflow of their blood will go in this route right here. It will back up here. And then blood in the line encourages and feeds bacteria. And it looks gross. So if you come in and there's blood in the line, clean, 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 get a new flush. We don't leave it like that. We don't feed the bacteria whenever they want.
So that will be like a clump, that green thing?
This is a clamp. There's a flat edge to it that it's easiest if you put your thumb there and your two fingers underneath and you push down. So it's a little clamp. Yeah.
So let's say you have an order for an IV, you will just come, clean the blue, and then attach the IV
Yes.
to it?
But I would honestly, personally, I would check the patency
Or
first.
always flushing to make sure you have no resistance?
Right.
and
Because you might be the nurse that goes and flushes religiously and does your assessment. But you may not work with other people who do that. That's been my experience in life. We always check before.
Is there like a recommendation like on how often you need to be flushing it? Like if it's just like that, like no IV
Yes.
fluids, no nothing.
As a nurse doing your assessment, assess once a shift, and that would include flushing. But generally now, because there were so many people that weren't doing it, they have it ordered at many hospitals. They have it come up as an order set or as a PRN, because we really should count it as our in and out too. There's 10 mLs it just pushed in the patient. So keep track of that if you.
Make sure it's open before you flush it.
Yeah, but you know that catches you though. If you're trying to push, you're like, oh my gosh, you'll be like, oh, it's okay.
So how many mLs
No
can you
harm
flush? Is there a limit like 1, 3, or less?
There is a limit. So for peripheral IVs, they recommend 5 mLs. It's okay to do more than that, especially think of what your patient's there for. If they're there for dehydration
Oh,
or
yeah, they want the
hypotension,
extra, huh?
just flush away. Have a happy. If they have a central line, you have to do 10 mLs per line, mandatory. So you'll probably do 30 because there's 3 lines on most of them. But that's hospital policy. You'll learn that if you're on those units. But they usually buy these in this amount for all the hospitals because it's cheaper to order one volume, one size. So that's why they don't have 5 mLs for your peripherals. But you can choose just to do 5 and throw the rest away. Totally fine. This you can squirt into the sink and just toss it. So that is it. There it is.